Wo sir, please go ahead. Pankaj sir and Himanshu Patel sir to be our panelists. Over to Hegde.
Thanks all the panel members. All the panel members, Pankaj sir, Himanshu, Dr. Lobo and Kalpesh. So basically, one of the most common disease what we face, almost 25% of the glomerulonephritis. So I will start with Dr. Pankaj sir. Earlier we used to call it diabetic nephropathy. Now we call more of a diabetic kidney disease. Is both are same or is there any difference?
Thank you, Dr. Hegde. I have been examiner for DM and DLB and PLB for last 20 years, and I am considered as a liberal examiner. Before 10 years, I asked the student that what are the reasons in diabetic nephropathy. Then my co-examiner said, what are the reasons of diabetic kidney disease? So that is the time I realized the difference between diabetic kidney disease and diabetic nephropathy. Diabetic kidney disease is a broad term, and it is a call for all the lesions involved in the kidney by the diabetes. So it includes diabetic macroangiopathy, diabetic microangiopathy, as well as tubulointerstitial diseases. So that is, and it also encompasses diabetic glomerulopathy or diabetic nephropathy, which is mainly glomerulopathy, and it consists, as we know, of thickening of the GBM and mesangial expansion, as well as glomerulosclerosis. So that is how we can differentiate diabetic kidney disease from the diabetic nephropathy.
Okay, thank you. So basically, nephropathy most of the time is by alcohol, or if there is any proteinuria, albuminuria is more than 200 milligrams. And now we know that in the Wikipedia, almost 40% had no albuminuria, but they were. So it's basically other mechanisms which are there in the range of ischemia, hypoxia, oxidative stress, and even most of the people are on good dose of ACE-ARB, it also reduces the proteinuria. So all these things contribute. So in a part and parcel is diabetic nephropathy, and then it also all diabetic nephropathy DKD, but all DKD is not diabetic. So the next is basically how to differentiate between all diabetics may develop a glomerular disease. So how to differentiate, because you have to plan a biopsy if you have a non-diabetic disease. So what are the points in favor for differentiating between the two?
I always teach my students and my colleagues that it is our task to differentiate NDKD from the DKD, because by diagnosing NDKD or non-diabetic kidney disease in a diabetic patient, it can change the prognosis, renal prognosis, as well as overall survival of the patient, and many conditions may be treatable. Non-diabetic kidney diseases may be treatable. I can recollect a case where one of my patients was having 10 gram of proteinuria, and his anti-K2R was positive, and I treated it as a membranous nephropathy, and patient responded well. I have also observed association of diabetic kidney disease along with obstructive nephropathy. As you know, obstructive nephropathy is when obstruction involves the kidney function. We call it obstructive nephropathy. As both are common conditions in our territory, I have seen that combination also. So NDKD may be present plus minus DKD. So and if we can differentiate, differentiate NDKD and treat it, it will change the prognosis. There are few features by which we should suspect NDKD, and they are severe proteinuria, as I told, more than 6 grams, active urinary sediment, rapidly falling eGFR, low eGFR with little or no proteinuria. Other complications of diabetes are not present, like without diabetic retinopathy, long duration, if duration of kidney disease is less than 5 years, or if there is a family history of other systemic diseases like polycystic kidney or SLE, and these are the features by which we can suspect and prove non-diabetic kidney disease in DKD patient, and biopsy can give us final answer.
Thank you, sir. Most of the patients, sometimes even though they don't have a points in favoring a diabetic kidney disease, we do a biopsy. Sometimes we see a mixed picture or even diabetic nephropathy, also almost in 30% of the patients. Thank you. So, it's again all lifestyle modifications are first, and then it becomes a drug. So the metformin, SGLT2, RAS blockers, and antiplatelet, all are the basics. So it was to Dr. Ruchi, I think I'll ask all the members, what should be the HbA1c, the target to reduce or retard the DKD? I think President. Okay. So basically what we saw in the earlier studies that HbA1c normally it is less than 5.2. So those patients who have normal, they don't develop any diabetic kidney or a microangiopathy. But in those who have a pre-diabetic state, when their HbA1c is 5.7, 0.4, the 5 to 20% of the people, they had microalbuminemia. So microalbuminemia starts early, but in these patients, there is no follow-up data what happens to them. Usually what we learn in diabetes, if you treat with ACE inhibitor ARB and the sugar control, 30% regress, 30% they remain the same, 30% progress. You don't have any data in them. So we have to be very careful. And if you did see study also shows, I think if you control it is less than 7 or 6.5 is better, you have reduced the and complications, and 1% reduction in the HbA1c indicated in 12% of stroke, 43% amputation, heart attack, and 20% mortality, and majorly 37% blindness and complications. So, but reducing further the ECHO trial, we had did not see any much difference, more mortality because of hypoglycemia. Even the same with the study. So we can take it as 6.5 to 7, but again we have to see all these patients when we are having it, the macrovascular complications, but not the macrovascular complications. They are clearly associated with hypoglycemia. They may not be able to improve, and we'll have to see for each person and see if they have a less than 2, when they have a lot hypoglycemia risk is less, then we can control better. If it is any vascular disease, elderly, liver disease, CKD, I think the control should be a little bit liberal to prevent complications. So now we have pillars of DKD. We have SGLT2, now GLP-1 in some, and ACE inhibitor ARB, and statin and non-steroidal agents. So to Dr. Lobo sir, and we know the blood pressure control is most important. And what should be the sweet spot to as to prevent? Because if you reduce also, it may create a problem.
So, like you said, there is the blood pressure control depends on the stage of CKD, the presence or absence of albuminuria, and of course in type 2 diabetics, the elderly, the age of more than 75 has been taken for maintaining a higher target. Generally, if there is no albuminuria, systolic blood pressure of less than 140 and diastolic of around 90 has been recommended. In those above 75 years of age, it is said 150 by 90. If the patient has albuminuria, then a little difference, just less than 130 by 80. There is some evidence, and some of the societies which have given guidelines say less than 120. A little controversy exists about that, because there is a J-shaped curve. If you go down to 110, then that's when the mortality actually starts to increase. Now, it has been said that if you go down to 120, you are striking a balance. There may be a few more kidney adverse events, but the mortality overall will increase. And as that last graph of yours shows, that's what happens. If you leave blood pressure untreated in a diabetic, then a patient will lose about 10 to 12 ml per minute per year of uncontrolled blood pressure. If you can control the blood pressure to less than 140 by 90, you half that decline in GFR. And if you go 5 to 6, and if you go down to less than 130 by 80, then you bring it down still further to about 2 to 3 ml per minute per year if you can target that as tight as possible. Once the patient is in CKD 4 and 5, because GFR will be lost rapidly, again the society has given targets of 140%.
Thank you. Which should be given a more important, diabetic control or
blood pressure control?
Thank you. So, blood pressure control is the fast most important, and again the RAS inhibitor is one of the most important therapies. So, if you have to use RAS, you have to use in all diabetics or those who are hypertensive, those who have microalbuminuria or no microalbuminuria, which are the things.
Okay. So, all diabetics, if provided you can use them, the caveat always is that when you use RAS inhibitors, monitor the serum creatinine or the GFR, and most importantly, the potassium. We would probably, though the cardiologists do it a lot, combine eplerenone along with a RAS inhibitor. The incidence of hyperkalemia goes up very significantly, sometimes life-threatening. Overall, there has been evidence from HOPE and micro-HOPE trials in type 1 and with IRMA, renal and various other trials in type 2 to show that there is an effect over and above blood pressure lowering, a beneficial effect with RAS blockade. That is that there is a slowing of the GFR which is over and above. Furthermore, the optimum dose may be much higher. There is one trial, William Causer's trial with candesartan, that showed that the optimum dose of candesartan for blood pressure control, the maximum, was 16 milligrams a day. They used as nephroprotective, they went up to two groups, one taking 64 milligrams and one taking 128 milligrams. And while there was no further blood pressure lowering effect, there was a significant renoprotection in the fall in GFR with the higher doses of ACE and ARB. So probably the maximum.
Losartan was also used, 100 milligram BD. So they show that there is no blood pressure reduction, but the proteinuria reduction was not there. Even after
and long before any of this, Dr. Mani used to give 300 milligrams of enalapril to his patients.
It's a uricosuric. When you are using 100 milligrams instead of 100 milligrams twice daily, it also has a proteinuria, anti-proteinuria over and above, but blood pressure reduction is stable.
And also candesartan has shown some benefit in retinal.
Increasing the doses reduce the proteinuria much better. So even the IRMA2 also has shown the same thing. These are all the guidelines. But only thing is, if the person don't have any albuminuria and then no hypertension,
there is no benefit being shown in those patients in progressing from normoalbuminuria and normotensive patients. The ACE inhibitor hasn't been shown to benefit them in preventing the development of primary.
There are some patients who are hypertensive. They know microalbuminuria, you can use it, but it has shown to be a minimal help in almost 8.9 to 9.8%. It is reduction in the new onset of hypertension. So, Dr. Himanshu, now everybody is embarking on SGLT2, even in diabetic, non-diabetic, heart, neuro, and even the liver to reduce care. So, what do you say about its mechanisms and whether it is going to that?
We know the SGLT2 receptors are present on proximity. 90% of glucose is reabsorbed from this receptor. Main mechanism lies in this segment. You can divide the mechanism in direct and indirect effect. If we see the direct effect, so primarily it improves the sugar control, that is by glycosodium. And second is natriuresis, by which it improves the blood pressure control. There is a primary effect. If we just see the secondary benefit, it will decrease the albuminuria by vasoconstriction and by better blood pressure control. Second is it reduces the weight of the patient by volume constriction, and second is the caloric burn because of glycosodium. Third, we can see the lipid metabolism shift. That is because of relative glucose deprivation of the tissue. It shifts the lipid metabolism towards the lipid metabolism, and by that it will decrease the cellular lipotoxicity. And the third is again the inflammatory markers, inflammation induced fibrosis. This is the main mechanism of SGLT2 inhibitors.
So all the studies, when you start and how do you monitor the results? Because it is a multiple mechanisms, multiple things, and even a pediatric would say that you should start in those patients for more than 20 ml of your earlier it was 30, now it is 20, and you can add on and you can monitor it in cardiac patients you can use early. So what are the evaluations before starting SGLT2?
This is basically the liver function test. We should see the anemia profile and peripheral vascular disease because of high risk of amputation. This is the main concern. And genetic variation.
Absolutely, they should. And before starting, whether you will start SGLT2 and RAS both simultaneously or you give some time. Because the cardiologists, they start both simultaneously. But the nephrologists start at least 4 weeks apart. First start ACE inhibitor and then they start either one of them because both reduce the GFR.
Yeah. So we should start AC inhibitor first, then we can add later on SGLT2.
So we should, if the patient is already taking a diuretic, you can reduce it because it reduces almost 10% of water loss every day and it may plateau up. So better to reduce it because it reduces the interstitial fluid rather than the vascular fluid. So the AKI chances are much better. With the urinary tract infection also, if the sugar is much better controlled, you can have the glycosuria will be less and the urinary tract infection will be slightly less. So, and if the patient already had acidosis, you can not embark on starting it. So, and all other guidelines have said the same thing, and the present trial, all others have shown almost 30% of whom 40% in across they have shown a benefit. So, to Dr. Kalpesh, now the new drug kit in the block is mineralocorticoid, which is there earlier, but now the non-steroids also have come. So, how does this mineralocorticoids reduce the CKD and even cardiac benefits? And why the Syndrome is superior among the other MRs?
See, basically, mineralocorticoids have been there in the market for many decades now. If we go to the history of mineralocorticoids, aldactone or spironolactone has already shown a benefit in many trials, and there were secondary endpoints in heart-related outcomes, heart failure-related outcomes. They've shown benefit in terms of reduction in the kidney disease progression. The only challenge what we were facing in the mineralocorticoid is that their androgenic side effects and the management of potassium. Because the only brand which was available is aldactone, spironolactone. Now, spironolactone has a very high incidence of hyperkalemia in CKD, including gynecomastia. So that is where the nephrologists were rather reluctant to prescribe this thing. And third is that it was not selective. It's a broad spectrum spironolactone. Now, with the advent of eplerenone, the incidence of hyperkalemia had gone down a bit. But still, the hyperkalemia incidences were challenging the nephrology community. However, with the advent of finerenone, that is the latest non-steroidal newer mineralocorticoid receptor antagonists, it is having very short half-life, and the beauty is that it doesn't have any metabolites. So the incidence of hyperkalemia is very minimal. It's highly selective, so the androgenic side effects are minimized, almost nil. So now the whole picture is divided whether the person is having heart failure, person needs a heart failure management, needs a CKD management, or we are using the mineralocorticoid for hypertension. So all three drugs have been split up into this. If you are primarily treating or prescribing mineralocorticoids, then you should use spironolactone. If you are using for resistant hypertension, eplerenone is a bit better than spironolactone. And if we are planning to prescribe for chronic kidney disease management, then finerenone is way better than all other available mineralocorticoids.
Hyperkalemia is a big problem which is much less convenient. So if the patient is having a 5.4 potassium with spironolactone and with gynecomastia, you want to change it to finerenone. So you can change it directly or you need to wait for the result.
I think it makes sense. Do not start any mineralocorticoid antagonists with more than 5 potassium. So hold aldactone or spironolactone. Let the potassium come down. Give anti-hyperkalemic therapy if needed, because we are not sure. Because spironolactone will take some time for its effect to go away. Now, on the top of it, if you add one more finerenone, then there is a risk of severe hypertension. So, wise way is go ahead, let the patient be off all mineralocorticoid receptor antagonists for a while, recheck the potassium. Once the potassium is less than 5, then reinitiate.
So basically, the spironolactone effect, which is the nephrology or active, it lasts around 3 to 5 days or 7 days. So if you start it early, then the chances of hyperkalemia it may further prolong. So better to stop it. And it has shown that when you start, it's much beneficial. It reduces the hazard ratio significantly, and when the cardiac mortality, heart, and even the Figlico analysis have shown a significant reduction in hazard ratio reduction by almost around 23%. And so it is beneficial. It is all are on O and above the ACE inhibitor ARB. So whether you can give without ACE inhibitor ARB, whether you can give before.
This is a debatable or questionable area. So can you prescribe Findrinol?
Because we are seeing prescriptions of
No, that is
without ACE inhibitor.
Now, see, we need to understand the logical way of this thing. The Findrinol works at a different level. The RAS inhibitor works at a different level, and SGLT2 inhibitor works at a different level, though they are all working complementary. Now, if you have one player missing, should you give the advantage of having two more players on the board or not? I would be in favor of yes, because it is not harming the patient. So I would consider giving, though there are no scientific data available as of now, but I would be in favor, though somebody can prove me wrong, but I would be in favor of giving
blood pressure control is only around 8 millimeters.
See, I'm not giving it for blood pressure, I'm giving it for chronic kidney disease management, because dying from ESRD versus a minimal risk of hyperkalemia, I would take by a minimal risk of hyperkalemia. This drug is truly a wonderful drug, mark my word, because it has shown after, I think, couple of decades, the drug has shown reduction in terms of prevention of end-stage kidney disease. Because we have had many molecules in the last 2 to 3 decades, none of them stood the test of time.
Moreover, kidney-driven trials, all trials were carried out on patients who were
most of the people were. But recently, just ending the fine DKD trial, they have the indication is not in the ACE. So there is indications are not included, but we included with the ACE but as a first-line therapy we need to use. But so that may show some of the patients who may not have an ACE inhibitor and those who are not able to comply or able to tolerate, they were given almost 98 to 99% were on disease.
I'll just add to it that Findrinol is being tried in many other diseases beyond nephrology. That is number one. And they are being tried in CKD, without proteinuria CKD, non-diabetic CKD. So we are going to see at least in next 5 to 10 trials are going to come up in next 5 years.
About the as of today, it is only approved for diabetic kidney disease, heart failure. He wants the patient to believe.
If you see the story of
even though there is no albuminuria, cardiologists say that it will be protecting to the heart to reduce the arrhythmia and also this. So it even though if you are not able to use SGLT2 inhibitors, no albuminuria, it may not benefit much. Even though it may also benefit in heart failure, not kidney failure, because the kidney function is normal, no albuminuria. It may benefit, but again, we have to be very careful in the complications and the blood pressure control has to be. And we may have to stop it when the patient gets the infection, and we need to stop it with the diabetes. So multiple trials are also coming up. The hyperkalemia 5, the sensitivity should be less than 5, should be stopped more than 5.5, 25% reduction in the progression of the CKD and also its benefits. So these are the others field coming up is fine one and fine CKD. And even in the transplantation, they come up. So we have to wait for the results whether it will be useful. So now the SGLT2 is one of the OHAs or the anti-diabetic agent which reduced the mortality. Otherwise, it was only the sugar control and even complications were reduced, but it did not increase or reduce the mortality. So one of the SGLT2 reduced significantly 30% mortality. The another drug is GLP-1 analogs. they are also useful. And what is your take about its mechanism and whether it also produces the mortality and also the
GLP-1 receptor agonist is a new weapon in our armamentarium as a rhinoprotective agent. It has a pleiotropic effect. It has effect on the brush border of the proximal tubule. It has effect on the ANP. Moreover, it has nuclear effect, which will cause decreased chemokines, cytokines, decreased addition molecules, and that is why it will decrease inflammation, fibrosis, and immune cell infiltration. It will also decrease apoptotic signaling, and that is how it has become. It is going to be one more extra weapon to us for renal protection in DKD patient and probably non-DKD patient also. There are eight trials conducted in more than 60,000 patients, and out of which leader trial, divine trial, and sustain 6 trial have shown beneficial effect on the kidney. And one dedicated trial carried out was a flow trial, which was prematurely terminated because interim results were so efficient that it was prematurely terminated, just like DEPA-CKD and EMPA-KIDNey. And so that is how this drug is going to be a one good drug with us as a for renal in DKD as well as non-DKD patients.
This indeed shows that very it reduces much more than what we anticipate. Reduces the systolic blood pressure and weight. Nowadays, most of the people GLP-1 is used for weight reduction, even non-diabetic patients also. So it's a good drug to have. Almost it reduces the atherosclerosis, and fibrosis, everything it reduces. As you told that even other anti-atherogenic effect is also significantly low, and that it reduces the plaque formation, platelet activation, everything. So it is shown to be beneficial, reduces the fibrosis, and you have said both the trials have shown significant benefit. It reduced almost the leader trial has been nephropathy by 22% and 36%, and divine as 15% per person. MACE events also significantly reduced, and even a stroke, everything is reduced. It reduces the sugar also. So, and another it goes to the finding that glucose independent rhinoprotective effect. It is also there. So, it basically will help in reducing and long-term CV complications also.
So it is said that GLP-1 receptor agonists have beneficial effect on the pump, pipe, and filter.
Thank you. So this was the statins also one of the pillar as a fifth pillar it has been used. And anybody wants to say anything about this?
Can I comment?
Yeah.
Before we proceed to this question, now anybody is prescribing GLP-1 receptor analog regularly in diabetic kidney disease patients in the crowd?
The cost is a problem
because it is not easy. Yeah, it is very.
No. Now there is an oral GLP-1 analog is also available. So that is why I'm asking if anybody has it, then you can share your experience about the tolerance and tolerance to the patient and pocketbook.
So basically, it causes more of a gastropathy.
If someone will use it, then let's.
You start with 3 milligram, it's a placebo effect. Minimum 7 milligram. Then you go up to 14 milligram. When you go up to 14 milligram, they start saying the early satiety, not able to use it, take it, and then even abdominal distension is the complaint what they complain. And nausea and feeling of not eating, people are hungry Yes, that is rebound is little bit, but again there is some gap. So then it reduces the weight significantly, but motivation.
I'm already diabetic.
Yes.
So there is a report that in US the diabetic patients are not getting it because it's been
US,
prescribed for the rest of the
US, everybody is taking for 14 milligrams, so it is not available.
Whether once a week injection will be all right for
It will be good. It will be good, but the cost is not available.
Ozempic is not available.
Prevention of
It is one of the filler they have quoted, so that's the reason.
but in chronic kidney disease, the issue is, as I discussed yesterday, rosuvastatin is here giving significantly. Atorvastatin is study maximum. And for kidney and also for the CV risk, if we consider, there are multiple trials like as I discussed, Stellar, it also included low GFR patients of even up to 30 ml. Dedicated 4D trial and Aurora trial and the SHARP trial. They included non-dialysis and dialysis patients.
No, it's basically a non-dialysis. Dialysis, I think they already lost the bus. Already they have everything. Using anything in dialysis may not be used. Should you start early because the dyslipidemia also starts. All these DKD patients, they have diabetes, so dyslipidemia is also part and parcel. So you have to have both. The CBD is also important. So we need to have, it's all pure effects again. It looks very nice, but how much really it makes any difference, we don't know. So all these trials have shown significant and even a diabetic patient. So they said that in non-end-stage disease, it may reduce microalbuminuria, but again, as compared to the other, the rosuvastatin, proteinuria, because of the tubular proteinuria, it does not because of the tubular proteinuria, and it also reduces the mortality. This is one of the meta-analysis have shown that will reduce albuminuria also, and even the mortality reduction, which has been shown. So I think it should be used early in if the lipid profile is abnormal, especially if there is any family history of any CVD and he had any symptoms, definitely should be used. But this Canadian network has definitely shown that when you use high intensity statin, you can get an AKI also. So we'll have to be very, very careful, even because most of the cardiologists have 18 milligrams or 40 milligrams. So we have to be very careful and we need to evaluate the patient. So one of the reasons for the AKI is that. So the recommended dose is only when you have 10 milligrams, 20 milligrams in AKI is good, and the rosuvastatin should be only 10 milligrams. So we have to be very, very careful.
See, again, this high dose and AKI, it's more of on paper because my cardiologist uses almost on all ACS patients 80 milligram after class. And that they, at the time of discharge, they make it 40 atorvastatin and they continue it for 3 to 6 months. Yet to see a patient who in last 7 years who had developed this. So I don't know the real time incidence of, though it is on paper, but
we have seen rhabdomyolysis.
It is, see,
especially in transplantation.
Rhabdomyolysis
when you use with
interaction with
phenotypes. Only this thing is okay. We use with phenotypes, your chances of rhabdo goes up. We've seen multiple.
Frank rhabdomyolysis, I've seen only one frank rhabdomyolysis where the CPK was truly high in 1000, and it took some time for the CPKs to settle down. It takes around 4 to 6 weeks to settle down.
But myalgia is very common.
Myalgia common, and that improves when you reduce the dose.
Yeah.
It is a dose dependent myalgia.
Yes. Yes. I don't know, because even a proteinuria now everybody accepts as an important marker for vascular disease and even the GFR reduction. So I think it requires re-evaluation by the market.
I think they are considering CKD as already damage has happened. So what they are thinking is
Is minimal. So
GLP-1 receptor agonists have shown beneficial effects in adverse disease.
So we have now other pathways are also available, like this logo, sir. So NRF pathways, they have detoxifying system of our body, and they have shown increases in the GFR also. Whether they are really worth considering, or in which subset of patients whether it is.
So not surprising that that question comes from here, where Dr. Agapeta has done so much of work on catalytic iron and versus oxidation stress. So as baldosterone is the prototype of this group of drugs. So there are others which are left in natural studies. So baldosterone has in all the studies that have been done, starting from being I think and then sugar. So every time there was an improvement in creatinine and GFR, but the first study Beacon showed that there was an increased hospitalization for heart failure, non-fatal myocardial infarction, and non-fatal stroke, and the study was stopped at 9 months. Now that study used rather high doses. It used 20 milligrams, which was equivalent to the 75 milligrams of the previous preparation that was used in the. And then Tobacco, which has not shown those cardiovascular studies, so it's a much smaller study, just like about 40% of this data. So they randomized over 120. They started with 5 milligrams. At 4 weeks, they increased from 5 milligrams to 10, and then to 15, and then to 20. So they've been much more cautious, and perhaps the optimum dose requires to be established. There are two other trials which are not yet being published, which are going on. IGA and Falcon is, I think, in ADP, and Cardinal, which is being used in alcohol. So these drugs are being used across the board. There are others in this group of drugs. When there is sulfuron hypertension, so there are a number of drugs which are going to act on this pathway. Perhaps what needs to be looked at is what we guys have already done. If you can show oxygen stress, then that's the group which will benefit from it.
Basically, otherwise, only the subset of drug which increases the GFR. Yes. Otherwise, we are all seeing for looking at the retardation of progression. But again, even the diabetic hypertension causes more proteinuria, and these drugs decrease nothing, and that is why the creatinine is possible. So it's increased the GFR, but again, the heart failure, edema, and proteinuria was much higher. And the Beacon study clearly showed that it was terminated even though the GFR increased. They had more and more hazard ratio of 0.83 reduction increase in the field. So this was the another trial which came later on, say looking at those who have ACR less than 300 and those who have BNP normal. In this subset of patients, it works well and there is no significance. So it's only the small subset where you can use these drugs to increase the GFR and retardation of progression further. So Dr. Himanshu sir. So even endotheliums are also come into the picture. Sonar and everything have shown. It also has reduces the CKD and blood pressure control. What is your take on it, and what are the concerns?
Basically, endothelin is increased in renal disease secondary to hyperglycemia and acidosis in hypertension. As we know, the endothelin will act to the endothelin receptor, which has a 3 subtypes, A, B, and C, and B has only 2 subtype more. I am not going in a detail. So ultimately, the nephrology is concerned, this endothelin will work on basically it will do the afferent vasoconstriction, and the second is podocyte injury. As the podocyte and mesenchymal cell has a endothelin receptors on it. The antagonist will work on this subset. By this, we can reduce the proteinuria and we can achieve the modulation in the intrarenal hemodynamics. And the third is the second, they also claim that the mesenchymal matrix achievement will be decreased, leading to less fibrosis in the kidneys. This is the main mechanism. The concern is I have not used any EP receptor blocker, and the cardiologists are using very much. Pulmonary hypertension.
But we are also seeing a lot of edema. Weight gain.
The common prescription is bosentan. The anemia, volume overload, liver dysfunction is more with the bosentan. That is the only concern which was having this.
What about the ARB and combination bosentan?
There are reports, there are studies ongoing. This endothelin receptor blocker and SGLT2 can be mixed for the better outcome.
So, the edema is a problem, so we need to have some of the diabetic control. So, the SONA trial also showed significantly that it had more and more edema, anemia, and heart failure, which are more common. So, even though it was good, but again, we will not be able to use it. Even the insights also shown that the albuminuria is acceptable to albumin. Safety with this already problem. You see that edema was higher and higher when you use it. So it was 1.5 milligrams higher, only in 0.25 only 1%. So edema and heart failure are the problems. When you use combined with an SGLT2, they showed that it will be able to excrete extra water and your edema and heart failure will be less. When of percentage which has an ARB plus endothelin, it's an IGA nephropathy, they are using it as of today. There is no trials in diabetic nephropathy. It may think we need to see in the future. Now, as a resident, we used to learn that 1 ml or 12 ml per year is the way GFR loss in diabetic kidney disease. So now, is it the same or is there anything that changed from 1980 to 2000 and when we call it rapid progressive disease?
See, in last 4 decades, what we are talking about, what is the development happened to reduce or retard the progression of diabetic kidney disease? The first trial which has shown that the antihypertensives did reduce the rate of decline in GFR. So if we calculate, suppose roughly, that GFR decline was 10 ml per minute per year, the antihypertensives has made it 9.5 or so. Then came the landmark trial of sugar control, that is DCCP and UKPDS index. These are the studies which have shown that the appropriate control of sugar will help you in preserving the kidney function over a period of time, and the effect will last for many years, even though it is a legacy of the glycemic control which will go on. Then 2 landmark trials like captopril and IGNT and renal trials which have shown that ACE inhibitors and ARB, in short RAS blockers, did help further in terms of reduction in the CKD progression. And in last couple of decades, what we see is SGLT2 inhibitors, that is in DAPA, CKD, Credence and many other trials of empagliflozin and so on and so forth. They have shown that the GFR can be preserved to a further extent. And the last molecule in the list is fentrinon, what we discussed. And if you see the fidelity, that is the pooled analysis of these 2 landmark trials, that is Fidelio and Figaro, and they've shown that the GFR, the CKD doubling of creatinine or reaching to the end stage disease, which is prevented in terms of 25 to 30% of the patients. So the hazard ratio was 0.77 almost for the secondary renal endpoints. So what we are seeing in last 4 decades is like less than 10 ml, or 10 ml reduction in GFR per year. From there, now we could achieve it to 2 to 3 or 4 ml reduction. So we are giving more number of dialysis-free years to the patient with the help of these molecules in last year.
So, and who we call now at this point of time the cancer rapid progression?
So usually the CKD progression happens in terms of 1, 2 or 3 ml per minute per year reduction in the GFR. But when the GFR progresses very rapidly, that means beyond 5 ml, then we will call it as a rapid.
So all 40, more than 40 is almost around 0.5 to 0.7 decrease. So even CKD and the degree of proteinuria, hypertension, everything matters, and how much it progresses. So in a mean in the GFR, the normal albumin rate is 2.3, and even a macro albumin rate will go up to 3.3 ml. So it is 1.7 normal urea, microalbuminuria 2.2. So even in the typhoid is the same. When you call as more than 5 ml reduction every year, we call them now as rapid progressive. We need to be very careful in evaluating them and treating them. So from 10 ml we can reduce it to 4 ml. Now we take to 1.8 ml. And another 13 to 15 years of more dialysis free time. So we have progressed from 1980 to 2020 as significantly retarded the diabetes nephropathy. And thanks to the panelists, and thanks, these are all the risk factors which I don't know. So thanks to all the panelists, and thanks everyone for staying, and sorry for keeping you hungry. Whatever the glomerulonephritis is submitted for the IF, whether they are okay or they are clear. No,
you could not send it for IF. You sent it for IF or you do not? EM नहीं.
What are the figures? So 10 grams is something glomerular or an acute onset. So diabetic nephropathy don't progress so fast. So I think the EM done. What about the plateau?
Now the creatinine was 2, you said. Yes. So what is the slope of decline in GFR? Is it like very slowly progressive declining in the GFR? And how are the kidney sizes? See again, immunosuppressing this individual will be a double-edged sword because you already lost a lot of significant GFR. If it is already progressing and patient has reached, you may add 2 or 3 years by immunosuppressing this person. Fibrosis.
Worth giving the steroid. I think you can give the non-steroidal therapy or reduce the dose of steroid, and if there is no infection and his fragility is not well. 10 grams proteinuria is not diabetic. Sudden onset, hypoalbuminuria is everything.
So they followed your protocol in lab. Pendrinon. I would add here, instead of that, do serum markers like membranous, plaque-R, and free light chain and myeloma panels and all these things. Because જેને પણ એને બાયોપ્સી ના કરવી હોય તોની વાત છે. બાકી
angiography can send for ESG.
Nephrotic presentation with diabetes is well known, including hypoalbuminemia. It is not like unheard. Yes.
When you have a significant, their proteinuria is significant and difficult, and the progression is fast.
Maulik, there is one more offer. If you don't want to spend a single rupee, send the biopsy tissues to IKDRC. They will do free of charge. Send the patient there.